Guyana is the only English-speaking and third smallest country on mainland South America. It is an upper middle income country bounded by Brazil, Suriname, and Venezuela. Guyana's population is less than 1 million, with a life expectancy at birth of 68.2 years. One third of the land area accounts for the coastline, and it includes the capital city, Georgetown. Approximately 90% of the population resides there. Although the incidence of poverty has declined since 1999, it remains particularly marked among indigenous and hinterland populations, children, and young people below the age of 25. Guyana's unemployment rate is 12.2%, with youth unemployment accounting for about 22.9% of this total. In 2016, the main sources of health finance were derived from government schemes, both central and regional government, national insurance scheme, voluntary health care payments, out-of-pocket payments, and unspecified financial schemes. The public sector contributed over 22 billion Guyana dollars to healthcare in 2016. Healthcare in Guyana is financed primarily by the government, with support from international partners, private firms, and households. Financing in Guyana includes public funding through loans and grants, indirect and direct taxation through the Ministry of Finance, and on a smaller scale through the municipalities of Georgetown. All the resources are then pooled into the Ministry of Health, the regional health authorities, and Georgetown Public Hospital, the only referral hospital in the country. There is also significant external donor funding and private spending through the National Insurance Scheme and out-of-pocket household expenditures. Healthcare in Guyana is primarily free of cost, with social health coverage designed to protect the most vulnerable. NIS was established 51 years ago, and it allows both the employer and employee to pay contributions into the scheme based on a payroll system. The total contributions for the employed is 14% of the actual salary. Employees pay 5.6%, and the remainder is covered by the employer. Only the ceiling amounts have increased over the years, not the rates. Private health coverage has remained stagnant over the past 18 years, with contributors ranging from 1.95% in 2000 to 1.5% in 2018. Unfortunately, there are no government reports on community health coverage in Guyana. Guyana's National Insurance Scheme, otherwise known as NIS, as seen in the table, is progressive. Both the poor and the rich pay a fixed percentage according to their income to social health coverage. The minimum wage rose from 39,000 Guyana dollars to 70,000 Guyana dollars over the past 5 years, allowing a minimum contribution of approximately 20 US dollars monthly for the population living closer to the poverty line. As seen in the graph, over the past 18 years, Guyana's public expenditure hovered at 50% and has seen a consistent increase from 2010 to 2018. This is comparable to other Caribbean countries like Trinidad and Tobago and Jamaica. General government expenditure on health as a percentage of the health spending accounted for 61.9%, a 20.7% increase from 2006. Information justifying the increase in expenditure was not found. Donor funding decreased from 40.7% in 2008 to 7.1% in 2014 to a staggering 3% in 2018. Guyana has a greater dependence on external aid compared to its CARICOM counterparts. Private health financing is dominated mainly by out-of-pocket payments, where in 2018, 32.3% accounted for the health expenditure, but has seen a decrease of 5.4% over the past 6 years. The relative amount of health financing was given as 4% in 2016 and 4.2% in 2018. This is slightly lower than the CARICOM average of 6.7% and also under PAHO and WHO recommended targets of 6% of GDP. The total public health expenditure as a percentage of the national budget increased from 9.8% in 2015 to 12% in 2018. The absolute amount of health financing is detailed in Table 1, where the values are all given in Guyana dollars with an exchange rate of 206 US dollars for one Guyana dollar. The total health expenditure exceeded 28 billion Guyana dollars, whereas the total health expenditure per capita was 38,000 Guyana dollars. Progressivity of the health financing system. The most recent study assessing the redistributive effect and poverty headcount differences after payments in Guyana was done in the year 2000. The redistributive effect remained positive after horizontal and re-ranking effect and vertical effects were considered. This income distribution makes payments progressive. However, Brazil, Guyana, and Jamaica have approximately 5% of the total households impoverished through health system contributions. Income payroll taxation system is also progressive, and the taxation threshold rates on chargeable income have decreased. The more you earn, the more you pay. In 2000, Guyana's households spent 1.73% of the total health expenditure, but the household with catastrophic out-of-pocket payments was only 0.6%, lower than Jamaica and other South American countries. The lower the proportion of households facing catastrophic payments was the fairer contribution of financial burdens across households. But is there still equity in health financing in Guyana, with out-of-pocket payments exceeding 30% in 2018? It is unclear. Recommendations for sustaining or achieving universal health coverage includes engaging in timely statistical health data collection that particularly assesses the effect of out-of-pocket payments on household and payments that plunges the population into poverty. Also, make this data readily available to the public. Strive to strengthen stewardship and governance to reform the structure of the Ministry of Health to better address health inequities, including redistribution of funds to the regional health authorities to prevent delays in purchasing health care supplies. Thirdly, provide more opportunities for employment in the formal sector that can actively contribute to social insurance schemes. And reduce foreign aid dependence by building on domestic investments and natural resources. Furthermore, it is imperative to make private insurance schemes more appealing by sensitizing the public about its benefits in order to reduce out-of-pocket payments and avoid catastrophic payments. Increase taxation on harmful health products, including sugary drinks and foods high in salt and trans fat that can then be pulled into health sector. Finally, it is imperative to incorporate community and microinsurance into the broader pool to fund health care costs for the vulnerable. These are my references. Gracias, and thank you for listening.